Oxygenation Part 4, this is Martha Olson, Iowa Lakes Community College. As we look at the phase of the nursing process for implementation, we know many things the nurse will do to promote optimal oxygenation in our patients. Incentive spirometer, cough and deep breathe, getting them up to ambulate, listening to lung sounds frequently, checking O2 sats. Those are all interventions that help us to know where their status is and also to promote optimal oxygenation. In nursing school, I went to a very large facility where we had the RT, respiratory therapy, 24/7. As I transitioned into my first job in a very small rural hospital, we did not have that luxury, and I had to learn how to do breathing treatments. I was kind of afraid at the beginning to do a breathing treatment, but as I quickly learned, patients are suffering without those, and it's not very hard to learn how to do those, and they do have much better outcomes when we are doing those breathing treatments in a timely manner. They are often ordered PRN, and it's up to the nurse to use good clinical judgment and assessment skills to decide if a patient in the middle of the night needs a breathing treatment because it's been several hours since they've had one. Most of your breathing treatments are bronchodilators, and they do help the patient to breathe easier and expectorate mucus and phlegm. As we look at oxygen safety, we know that oxygen is very flammable and would never ever be used around an open flame or cigarette smoke. In the hospital, every facility has oxygen shutoff valves strategically placed throughout the hospital, and it's important that nurses know where those are located. In the event of a fire, they would be able to get the oxygen shut off so that the hospital does not go up in one big poof. As we look at interventions related to airway management, we know that sitting up in that orthopnea position, having the head of the bed elevated, does help a patient breathe easier. As we look at our CPT, chest physiotherapy, treatment is used to help clear the chest of excessive bronchial secretions. And as a nurse, we have to think about doing that safely. Somebody with osteoporosis, we would not want to be cupping our hands and beating on their chest to loosen secretions because we actually could cause fractured ribs. You would never want to do chest physiotherapy after someone has eaten, because when you reposition them and start beating, or doing physiotherapy on that chest wall, you could cause them to aspirate what they have just eaten. So before meals is usually much better. When we look at the technique with chest physiotherapy, percussion is where the chest is struck rhythmically with cupped hands over the areas where the secretions are located, usually in the lower bases, or if somebody is laying on their left side, it will mostly be in the left lung because that's where the secretions tend to go. As we look at vibration, that is usually where the hands are used vibrating over the chest. I've seen some of these little instruments where they will do the vibration for you, kind of like little beaters that you plug in. And then your postural drainage is using gravity to assist the movement of secretion. So a patient that only lays on their left side would be encouraged to change positions throughout the day and night to promote drainage of that fluid in the lungs. Clients with unilateral lung disease such as a pneumothorax or atelectasis position with the healthy lung down. This promotes better perfusion of the lung, improving the oxygenation status for that patient. Other interventions related to airway management would be the incentive spirometer. Several questions on the test related to the use of an incentive spirometer. It helps improve ventilation by loosening the secretions, and the patient will let all of their air out and then take a very large deep breath in. That's why it's called an incentive spirometer. Underline, it prevents or treats atelectasis because it helps expand those collapsed alveoli. When you take little shallow breaths, it doesn't open and close those alveoli, but when you force a patient to take a good deep breath, it brings fresh air all the way down to those alveoli, opens them up, oxygen and carbon dioxide exchange places, and the patient then has a much better oxygen saturation. As we look at the assessment, we need to look at patients or clients that are at risk for atelectasis, those that are on bed rest, those that have weak musculature, your obese patient that doesn't take a good deep breath because of the weight that they are, and we complete that respiratory assessment, again using many different types of skills, looking at percussion, looking at, their O2 sat, their color, all of those things, and then look at what the physician has ordered. So we can follow the treatment protocol very closely. And sometimes respiratory therapy will have a few suggestions of different things we can try as well. As we look at other management tips for the nurse, our dyspnea management. When your patient is very short of breath, the medications are breathing treatments. They're called different things. They can be called an egg core neb, ACN, handheld nebulizer. They're all the same thing. You put the medication in the little cup. It goes on either through a pipe or through a mask to the face, usually for about 10 minutes with the patient sitting up. Your oxygen during a breathing treatment is cranked up to about 7 to 10 liters per minute. You don't want it any higher than that because it forces the medication in too quickly. And if you don't have it up to about 7 as a minimum, it will not have enough force behind it to get the medication down into the lungs, down all the way to the alveoli. As we look at physical techniques, we're looking at repositioning, coughing and deep breathing, applying oxygen, and then psychosocial techniques are things that help promote relaxation for the patient. When you have a patient that has a chronic long-term respiratory problem, many times they're anxious. It's a lot of work to breathe, and they become very underweight and anorexic because they have no appetite, because they just have so much work in breathing. Most of those patients that I've cared for like the room cooler. They like a fan on the floor, kind of moving the air around, because in a warm enclosed place they feel kind of trapped. And the patient that's having difficulty breathing oftentimes will have a lot of anxiety with that. It's kind of like having an asthma attack and you're struggling and working so hard to breathe that it causes you a lot of undue anxiety. With the orthopnea position, they must sit with their arms elevated and leaning forward to breathe, and that orthopnea position oftentimes becomes the bedside table. They have their feet hanging down over the edge of the bed and they are kind of resting or sitting up with their arms over that bedside table. In looking at some of our other interventions, your textbook talks about the cough techniques called the cascade cough, the huff cough, and the quad cough. Those are just a series of coughs that promote the alveoli to open and close effectively and for the person to be able to get more air in and improve the oxygenation. As we look at the turn cough and deep breathe, usually the patient will take a couple of good deep breaths, and then on the third deep breath in, we tell the patient to do a good cough with that. As we look at our suctioning, the different types of suctioning are listed here. Oral is oral. Nasal is in through the nose, so we can suction through the mouth, through the nose, or we can go down into the trachea. So that would be through the mouth down to the trachea, through the nose down to the trachea. Or if somebody has a tracheal place where they maybe have oral cancer and they have a trachea placed, they would then, you would be able to suction through that area as well. As we look at our other interventions, we have an oral airway. These are talked about in your textbook. The oral prevents the tongue from occluding the pharynx. It's a picture. It's just a hard piece of plastic that's fitted to the jaw for the size of the person. And then our tracheal artificial airway, usually your nurses will put those down after it's been established if it's a trachea or an endotracheal tube. Nurses with advanced skill are taught and are able to put an endotracheal tube down using the laryngoscope. As we look at mobilizing those secretions, we want to hydrate. Keep the patient drinking water because, as I said, it thins the secretions and helps them expectorate them much easier than the thick, sticky secretions that they can have. When we humidify, put a star on that. That helps keep the airways moist. It helps loosen secretions. And when you look at the oxygen on the wall, it's got humidification. It's got the bubbler right there with it because oxygen is very drying. And if I have oxygen in my nose for a day or two, my nasal membranes get very dried out. So we try to humidify the oxygen. And then with nebulization, that's moisture and medications. We mix those two together, and that's our neb treatments or our breathing treatments that we give. The aerosolization suspends the water droplets, and so they are able to breathe those in and they get all the way down into the lungs to do what we are wanting them to do. So our handheld nebs, acorn nebs, are our nebulizer treatments. With that, as I talked about before, good oral care, because you can grow bacteria very easily in that mouth that does not get good care after. So when you give a breathing treatment, offer the toothbrush, mouthwash, anything to get that mouth rinsed out and cleaned out. As we look at our pursed lip breathing for the patient that has the chronic conditions, it's where they take a good deep breath in and then prolong twice as long to breathe out, or have the expiration phase through pursed lips. And the pursed lips kind of relax the alveoli and allow them to collapse, so that when they take that breath in, all the stale CO2 has been expelled, and they now have room for the fresh oxygen that is being breathed in. Your diaphragmatic breathing is another type of exercise where the client relaxes those intercostal muscles, and they do that along with the pursed lip breathing. When we look at other things we do, our chest x-ray is a very common type of intervention that you can see ordered by a physician. It's usually ordered AP and lateral. AP is anterior, posterior, meaning we do a front to back chest x-ray, and then the lateral is have them do it through the side. Anybody going for a chest x-ray, you would not want them to have a necklace or any buttons or snaps, anything on that is going to show up on that chest x-ray. Your sputum CNS, good to know. Usually try to get it early in the morning before breakfast. Lab does not really want to know that they had scrambled eggs for breakfast, and when you get a sputum culture, it's got food particles in there. Do not have them spit, but have them take some good deep breaths and get some phlegm all the way from down in the lungs. Make sure you label it and get it to the lab right away to be processed. What they're looking for in a CNS, culture and sensitivity, is what bacteria are growing, and the S, the sensitivity, is what antibiotic will take care of the bacteria that we have found to be growing. ABGs are arterial blood gases. Those help us to know the pH, the O2, the CO2 levels in the blood in the arteries, what's going out. So after it leaves the left ventricle, we look at the arteries to see what kind of healthy oxygen is in that. And we also look at like your hemoglobin. We look at red blood cells to know what is the problem, that the person is cyanotic and short of breath and anemic. Our pulse oximetry is what we put on the finger, and remember our normal is 92, 95 to 100% is optimal. Your bronchoscopy is a visual exam using a scope. You can see that scope at the end of that word. We go down into the bronchia to either get some tissue, remove a foreign body, or just to visualize to see what is going on. You're all familiar with the tuberculosis skin test. We do that on a yearly basis for all healthcare providers, and also for your patients that are going to the nursing home or other conditions where they require to show that they are, negative with tuberculosis before they are admitted. It would be intradermal, and when you administer the tuberculosis intradermal, you want that little bleb on the skin, and you read it 48 hours afterwards. And then your pulmonary function tests are done with people to see how well the lungs are functioning for them. I know that was done for a young gal that kind of had an asthma attack, and they found out that about 20 to 30% of her lung was not functioning like it should have, and that's why she was having such difficulty with participating in sports. As we look at things to promote optimal oxygenation, living in New York City with all the smog is not healthy for the lungs. Your coal miners that are down breathing that coal dust on a daily basis. And we think about what are we doing to protect lungs. In this area, we look at the farmers, and they're breathing maybe moldy corn that's been stored in a grain bin all year. Maybe they're doing chores in a hog building where it's very dusty and the manure is coming up from the pits, and we have problems with patients like that. You look at smoking, adequate hydration, secondhand smoke, farmers that are exposed to chemicals. And the other big thing in this area is the farmers that are putting on the anhydrous ammonia in the spring to their crops, and breathing that is deadly. And oftentimes we will have farmers that come in with different oxygen problems related to their profession of farming. We will continue on with part 5 of oxygenation and wrap this unit up. Thank you.